So my name is Safwan Alomari. I am one of the research fellows working with Dr. Brem in the Hunterian Neurosurgical Laboratory. I'm going to present some of our work about developing a minimally invasive brain tumor resection model in rodents as an opportunity for a standardized resection process and automated tissue preservation. So I have no disclosures. However, this work has been supported by Nico Corporation. So the problem we're trying to address with this paradigm is the low translatability of preclinical studies on brain tumors. And several reports have estimated the clinical trial success rate in oncology in general and a brain tumor in specific to be less than 5%, which is unfortunately very low. And over the last decade, there has been a growing call in Nature Communication, clinical cancer research, among other research committees and groups to improve the preclinical environment as a step toward increasing the clinical trial success rate. So the majority of current preclinical studies on therapeutics for brain tumor research do not actually include surgical resection in their models, which is opposed to the case in the clinic where surgery is the mainstay treatment option for patients with brain tumors. The reason behind that is that currently available resection model include relatively extensive and invasive steps in these small animals. So, for example, if we want to do surgical resection, we need to do multiple burr holes, craniotomy, remove the bone, using the suction to resect or really aspirate part of the tumor in these small animals, and then homeostasis, putting the bone back, and then a closure. So doing all of these steps can lead really to significant morbidity and mortality and significant blood loss, especially for relative to the small volume of circulation in these animals. And also doing these steps under the surgical microscope in such animal models, time consuming, can take up to 20 or 30 minutes per each animal, while the paradigm that we're going to present today can do the resection process in less than 2 minutes. In addition, the currently available resection models are operator dependent and actually have experimental variability in regard to the volume of the tumor resected from one animal to another and from one researcher to another. So to address these limitations, we at the Hunterian Lab, and of course through scientists and engineers at NICO and collaboration with Dr. Woodworth and his research team at the University of Maryland, we developed this minimally invasive approach as an opportunity to standardize the resection process in these animal models. And some of the neurosurgeons might be familiar already with this system, as its clinical version is being used in the operating rooms in multiple institutions. So here to the left, to the right of the picture, this is the machine that runs the system and actually generates or creates a vacuum or negative pressure. And it's actually connected to the handpiece. This is the handpiece with blue and white color, and this is the resection cannula. And a good point about this paradigm and that this handpiece can be attached to a stereotactic frame, which allows the user to precisely and accurately use the coordinates in the stereotactic frame to locate the tumor and get a biopsy in the accurate position. And here is a schematic illustration of the resection cannula. And this is actually 23 gauge, which we use in mice, but it can be changed according to the need. So for relatively larger animals like rats or rabbits, we can use 19 gauge. Neurosurgeons use a 15 or 13 gauge in the operating rooms. And as we see here, there is aperture on one side of the resection cannula. And this aperture has a resection blade, which can go up to a speed of 1400 cycles per minute. And this actually allows to non-ablative resection of tissue without inducing heat or thermal damage to the adjacent brain parenchyma. And whatever tissue is sectioned is going to be vacuumed here through this resection cannula, and it goes all the way through this closed tubing system, and eventually it settles down here in this sterile container. And this is one of the advantages of this system, as mentioned before, because it actually allows for automated and quick tissue preservation, which can be used for translational research or biobanking. So we did this experiment as a proof of concept that resection using this paradigm can lead to a significant debulking of the brain tumor in these small animals as compared to the case in the clinic. And we used 20 mice. We implanted them with GL261 glioblastoma cell line. And this cell line is tagged with luciferase, which enables us to track the tumor burden using one of the bioluminescent imaging. And here on the x-axis, we have days following tumor implantation, and on the y-axis, we have the tumor burden. And day 0 is actually the tumor implantation day. Day 10 is actually the surgical resection. And we have this red curve is actually the control, no treatment group, where the animals did not underwent any intervention. And as we see here, the tumor burden continues to grow until all the animal dies at one point. And then this blue color represents the group that underwent surgical resection using this paradigm. And as we see, the tumor burden was significantly lowered after resection. And then after that, it seems that the tumor, the residual tumor led to a tumor recurrence, which led that the animals die, but at a later point of time. And we validated this concept in 2 cohorts of animals, in both a cohort that has a small baseline tumor and cohort that has large baseline tumor. And we found the same exact trend as you see here in the right picture. And this is a T2 weighted MRI coronal view of one of the animals undergoing the resection. And the top row here is actually the pre-resection stage. And as we see, this is the tumor established in the left hemisphere, and this is the tract of the needle used for injecting the tumor. And then the lower, or like the bottom row, represent the animal after, like post-resection stage. And as you see here, this is the resection cavity created by the paradigm. And this is the tract of the resection cannula, which actually uses the same tract that was used for tumor implantation initially. And one advantage of this paradigm, it allows for it allows the user to determine and adjust the volume of tumor resected per animal according to the number of rotations of the resection cannula inside the tumor cavity. So the resection cannula can rotate inside the tumor cavity, can make 360 degrees, 1 complete turn, 2 complete turns, and so on. And the more turns, the more tissue resected. And based on this MRI, we quantified the amount of, or the volume of tumor resected per turn. And one complete turn leads to a resection of around 10 millimeter cubic, while 2 turns leads to around 23.2 millimeter cubic of tumor volume resection. This is a coronal section of one of the animals undergoing the resection. And here on the left side, we have the resection cavity created by the paradigm. And then we have residual tumor at the periphery with invasive tissue. And this is just to show that resection using this paradigm can recapitulate or eventually maintain the invasive nature of these brain tumors or gliomas. So we did this survival experiment, and we found that a resection of the tumor using this paradigm can lead to a prolongation of a tumor-bearing mice by 7 to 9 days. And all of the animals undergoing the procedure did not develop any complication. All the procedures were uneventful. And we also validated this in 2 cohorts of animals, one with a small baseline tumor and one with large baseline tumor. And this experiment shows that the tissue resected using this paradigm has a high viability, both in vitro and in vivo. And the picture to the right side actually shows the microscopic picture of the tissue resected using this paradigm, how it looks like under the microscope here. And then we took part of these fragments and we implanted them in a new group of naive mice, and we followed them. We found that a resected tissue using this paradigm can actually showed actually the same growth and survival patterns when compared to the parental tumor. So this table summarizes the advantages of this paradigm over the historical or classical resection way. And as we discussed, it actually needs minimal scales because everything is automatic, and minimal operation time, less than 2 minutes, minimal to really no or zero blood loss, and a standardized volume of resection and automated tissue preservation. So let's go back to the question we asked first, how these advantages in this paradigm can serve us to improve the preclinical environment and to increase the translatability of preclinical studies. So of course, this paradigm by itself, it will not solve the whole translatability issue, but it addresses one aspect of them, which is actually including a standardized resection in preclinical models. And I would like to highlight some of the points on how resection using this model can help translation of brain tumor research from a local drug delivery perspective, as it is one of our focus in our laboratory. So as we discussed, it leads to standardized resection, decreased variability, and decreased confounding on the results, which increase the translatability later on. So for example, if I'm investigating a drug X against a glioblastoma, and I have two groups, one group treated with drug X and a controlled group that is not treated, and I want to include the surgical resection in both the groups. If I use the historical or classical resection model, I might resect more volume of tissue in the treatment group by bias, by chance, or whatever reason. And then this will lead to more favorable outcome or like better survival in the treatment group. And this will lead me to think that, oh, my drug is working, and then I will go collect some money, go to the clinic, do a clinical trial, but I will not have the same results. Also, as we discussed, it leads to decreased blood loss, morbidity, and mortality. And this really can be cost saving for the labs, because especially for labs using large cohorts of animals in each experiment. Sometimes in our lab, we use 400 or 500 mice per experiment because we include multiple therapeutic arms. Or for scientists who are using expensive species of mice, like humanized mice or mice with knockout mutation or treated with expensive drugs. So losing these, like a group of these animals, even if it's a small number, but over the long term can be really expensive for labs. Another indication that we can use this paradigm for is to create a cavity in the brain tumor for local delivery. So we have one of the collaborations with engineers at Harvard, MIT, and we're developing a platform that includes a hydrogel, and that hydrogel is loaded with multiple immune therapies to be delivered to the tumor bed. And then one of the issues that came up with this hydrogel is that when we're trying to inject it into the tumor cavity, after a certain volume, the hydrogel starts to seep out around the tract of the needle and goes to the epidural space or even external to the skull. However, when using this paradigm, it can lead to creation of a quantified volume inside the brain tumor that can accommodate the whole volume of the hydrogel. Can be used also for implantation of organoids. As we know, organoids are becoming the popular, maybe the most translatable patient-derived xenografts for gliomas. And they are really pieces of the tumors, not cells. So they need a space inside the brain of these animals to be created and accommodated. Another point that we can use this paradigm in is for acquiring rapid diagnostic biopsy, not necessarily for brain tumors, but any lesion inside the brain or the surrounding brain tissue. And it can be accurate, as we mentioned, because it's linked for a stereotactic frame. And it's also reproducible because you can go every time using the same stereotactic frame, the same coordinates, you can go for the same point and get a different sample from the same site at every time interval. And another point that I thought it could be of interest for scientists or PIs applying for grants. I remember we have applied for NRO1 last year and for the NCI, and one of the critiques by one of the reviewers came as a weakness of our proposal because we included the classical surgical resection. And then the reviewer said how we can make sure that the volume of resection inside each group is equal. So really including this paradigm in research strategies can flip that weakness into a strength. And now we're working with NICO scientists to really expand the scope of minimally invasive approach and automated tissue preservation in other oncological research like liver tumors, head and neck cancers. It can also be used in preclinical models of cerebrovascular models. So we're trying to implement this in creating preclinical models for strokes or intracerebral hematomas, where the resection cannula can be used really to either establish the hematoma or even evacuate the hematoma, or even for biopsying the adjacent brain parenchyma for scientists interested in investigating the impact of stroke, for example, on the cascades in the surrounding brain parenchyma. And I would like to thank the whole research team at the Hunterian Lab, our director, Dr. Henry Brem, Professor Betty Tyler. I would like to thank also Dr. Woodward and his research team at University of Maryland, and of course, NICO Corporation, Jim Pearson, Joe Mark, and all the wonderful team there. And happy to take any questions at the time and the moderator allow. Thank you.
Dr. Alomari, you hit it out of the park with that, not only presentation, but more importantly, the work. And, you know, for forever, really, we've been so limited with brain tumor research as surgeons because of the facts you stated that you're able to effectively and sort of, in a way, stereotactically or precisely resect. You have a very good resection tool, and you're able to keep the animals alive. So those are all big advances. How do you see this changing as we go into more preclinical trials? How do you see this changing the potential for researchers and neurosurgeons to get involved? And how would this inform and improve the potential for future studies?
So yes, it's just the start now. I'm sorry. So now only a few institutions have this paradigm and are using it. But of course, with time, we are anticipating if different institutions are using the same paradigm in the same standardized fashion for all the preclinical studies in brain tumors, then this will hopefully lead to a more translatable preclinical studies. But yes, this will take a significant amount of time to incorporate this paradigm and eventually most of the preclinical studies.
Questions from the audience?
Great talk. Just a question. Have you seen any interest from any pharmaceuticals, drug companies for any preclinical delivery of medications, treatment within the resection cavity that you guys create?
I'm sorry, can you repeat the question again?
You guys in the resection cavity created, have you seen any interest or any from pharmaceuticals or drug companies for delivery of treatment within the cavity for difficult to resect areas that can't get a
Yes, of course. The question is, the answer is yes, because now, like from now on, we're going to try to incorporate this paradigm in all the projects that we have local drug delivery interest in. And most of our polymers or local drug delivery vehicles in our laboratory are through collaborators with engineers, for example, from Harvard, MIT, from University of Cincinnati, from some group in UK, and other groups. So most of them are from research collaborators, but we have also few from companies. But yes, all of them has interest in including this in the model of investigating their drugs.
Dr. Rucker?
Really just a word of congratulations. It's the first time ever I've seen a surgical resection model in a rodent. So yeah, really fantastic to see that you put this together. I guess a question, and I think it'd be very valuable for serial propagation because it's so easy. It says 2 minutes for you to resect the tumor. So imagine you can just take a patient-derived xenograft and just transplant it, serially, easily. So I think that's a huge advance if you haven't done that. But this is done stereotactically, right? So you don't really see what, the tumor interface or those things. But I wondered if you implanted cells with a tag on it and you had a tip of your NICO device that could identify where there might be residual tumor hidden up in the high corners or lower down that could be activated, and you could try to extend your resection to a maximal point. That might be an interesting tweak on your system you might think about. But really wonderful work. Congratulations.
Thank you, Dr. Rutka. Actually, it's a great question, and yes, we're working on this question. We have two answers. The first answer is also through NICO. Now they have developed an addition to this handpiece that can be linked to a certain light with a certain wavelength that can detect specific fluorescent stains. So if we can stain that tumor with this stain, it can be visualized through this. The other answer could be the ultrasound. We are also working with some people on improving the resolution of the ultrasound. We tried this in our mouse model. The ultrasound resolution was suboptimal, and we could not identify clear anatomy. You could find the tumor, but we couldn't find different areas of the brain or different areas of the tumor. So now we're trying to push that forward to increase the resolution of ultrasound. We're using also sometimes MRI, but it's very expensive and not practical. But at the current time, we only just use MRI to do this. Thank you.
Do you foresee any potential application for ICH or vascular disease?
Yes. So the next step we are doing is to establish intracerebral hemorrhage model in mouse. So we can go with the stereotactic frame to the area that we want in the brain, and then we can inject amount of blood to form either hematoma or a clot. And then it can also be used for evacuation of the hematoma, or also biopsying the surrounding tissue around the stroke. Some scientists are interested in investigating how the stroke impacts the normal adjacent brain parenchyma over different time intervals. So using this system or paradigm can also allow us to go accurately for the area that we want and then do serial biopsies over time.
To me, nothing would lend itself better to post-evacuation therapy injection would be than ICH. And whether that's an anti-inflammatory or omega-3 fatty acid or any number of things, I think it's there for the taking if someone can work on it. How about rat versus mouse model? What are the differences and any advantages of either one?
Yes. So both are still a valid models, and Dr. Brim can speak also about the rat model, because when he developed the glioma, he used the rat model. But now as the time evolves, several papers have shown that the immune system in mouse is more comparable to the humans. That is why we now shifted our research into using mice instead of rats. But that is from a translatability point of view. However, this is for brain tumor. For cerebrovascular, the larger the model is, the better, because we want anatomy or dimensions that are closer to the humans. So rats or rabbits or larger animals can be also more valid for cerebrovascular research. But regardless of the model, this paradigm can be changed to accommodate for this need.